I would like to start with saying thank you to the Saudi Association of Radiation Oncology, Magnetar, and Electa for facilitating this, arranging this meeting. Also, Professor Doug Konzioka, thank you for accepting the invitation. Professor Doug Konzioka is very well known for everyone in the neurosurgical field, anyone who's dealing with the CNS pathology, either from a neurosurgical aspect, medical treatment, or radiation aspect. His experience go back to more than 35 years ago. I was trying to find through the AI what was his first publication. And the first one popped up was 1990 with Dr. Lunsford about AVM, natural radiation, 2 years outcome of AVM post-radiation stereotactic radiosurgical treatment. If that's correct, he can correct me during his talk. So that was 35 years ago. We know Dr. Konzioka from two chapters, the University of Pittsburgh chapter, and then the NYU chapter, which he's currently holding two positions with the neurosurgery and the radiation oncology department. He's the chair and the leader of the Advanced Radiation Oncology Center in New York. Me personally, I know him from two occasions. When I was studying for my board, I remember reviewing his papers for trigeminal neuralgia. That was my reference. I still have a hard copy of that, marking his conclusions. And another experience was when I went for my fellowship. I was going between Stanford, NYU, and Pittsburgh for interview. And there were two big news at that time at NYU. They have the news was roaming around that Dr. Konzioka was joining NYU, and everyone was excited, and was also Dr. Chandra Sen. So they both giant in our field joined NYU at that time. I wasn't lucky enough to be one of his fellows. I went to Stanford with Dr. Griffith Harsh, but I think you cannot go wrong with both of them. Dr. Konzioka, we're happy to hear from you, your experience, 35 years experience. Before you start, and we'd like you to know that we have one Gamma Knife machine in Saudi Arabia. It's more than 20 years old, and we have 7 CyberKnife machines. So a lot of questions will come at the end about CyberKnife versus Gamma Knife. We don't yet have a proton beam. Proton beam is coming this year in Riyadh in King Fahd Medical City. It's a national project. The talk will be 45 minutes. So we're going to receive questions in the last 15 minutes after Dr. Konzioka conclude his talk. Dr. Konzioka, it's an honor presenting you. The podium is yours.
Oh, thank you very much. Assalamu alaikum, everybody. And I wish you had come. I wish I was so fortunate to have you as my fellow. Maybe we could have done some great things together. So I'm really delighted. My wife's sister was the dental hygienist to the King of Saudi Arabia from 1999 to 2012. So she traveled the country as part of the entourage, taking care of the king, and she met her husband, who was a anesthesiologist at King Faisal in Riyadh during the time, and then they returned to Canada. So this is my family connection up to the royal family of Saudi Arabia. So it's a lovely treat. I don't have any disclosures. I don't have stock or ownership in any of the radiosurgery companies. I have some research funding from BrainLab regarding some software development. But I'm the editor of Neurosurgery, one of the main journals in the field. And so one of the things I do is to get to see a lot of what is the research that's being done across the world. And I want to share some of that with you as it particularly relates to brain radiosurgery. There's been a lot of changes over 35 years or so since I first got involved. And I got involved at a time when I really thought this was going to be the future of the first biologic surgery using radiation energy. And it changed radiation oncology, and it changed neurosurgery in many ways. And there's been so many changes that we can discuss today. And I got to work with a lot of fantastic radiation oncologists, as you can see in different institutions over the years, both in Pittsburgh and in New York City. So as was mentioned, there are different technologies. You have multiple CyberKnife units in Saudi Arabia. A proton beam is coming. You have one Gamma Knife that's established. Of course, there's modified linear accelerators. You can see this is New York City. This is the Gamma Knife being removed from the hospital by a crane after a massive flood in New York City destroyed most of the most of the hospital itself. In fact, you can see the Empire State Building in the background. And there's so many issues, you know, how radiosurgery fits into a neurosurgery department or a radiation oncology department. How do we train residents in these different disciplines to be able to do this? The government is often involved in terms of approving the purchase of different units. They have different costs. Who tells them what to do? And these are challenges from 30 years ago, 20 years ago, and they're still current challenges. But there's been a lot that's happened over 40 years. AVM radiosurgery of vascular malformations is now very common for all the difficult ones. Vestibular schwannomas, it's really the commonest procedure done for vestibular schwannomas, more than resection. Meningiomas for all the leftover residual tumors or difficult location skull-base tumors. It's still uncommon for creating lesions for movement disorders, but very common for trigeminal neuralgia, as was mentioned in the introduction. And it's the #1 indication worldwide for brain metastasis, as we'll show. So I mentioned this change between biologic neurosurgery and this evolution of precision radiation oncology. This has been this fusion together, and neurosurgeons for many decades have played with energy. We have frozen brain tumors, we have lasered brain tumors, we've radiated them, we've put probes in and used thermal energy to heat them up. And so over the years, the best, most controllable energy source has been radiation. And as you know, there's an emerging interest in laser back to light with laser interstitial thermotherapy. And believe me, all of these things come in circles and many of them will come back again. And of course, we have cells and viruses and other types of biologics as well. And perhaps in the future, there will be a merger of these disciplines, and we'll have centers for radiation medicine, centers for cellular surgery, doing whatever is best for the brain, the body, using neuroanatomy, neuroscience, radiation biology, technology, software, imaging, with great engineers working on these elements. I'll talk a little bit about artificial intelligence tools that are coming as well. Since I arrived at NYU, I've cared for about a little bit more than 7,000 patients. And you can see the sort of the breakdown across my own practice. And I do about 600 of these cases a year as part of my neurosurgical practice. Give you a little bit of history of which is always fun to go see. We talk about a proton unit. The first foray into radiosurgery starts with proton beam technology. And there's Lars Leksell, the older fellow in the left image, working with the physicist Börje Larsen. The concept was interesting, but it was not practical for a hospital. So they looked at practical systems. And the first device was a linear accelerator, which you can see on the right. But these devices just weren't up to the task in the early 1960s in terms of their reliability. And so they built this hospital-based system, the Gamma Knife, with very few moving parts. The radiation sources don't move, unlike a proton or a LINAC. The only thing that moves is the bed. And the bed is placed into the focal point of the beam intersection, and the shapes of the beams can be changed. And this was the first unit, 1967. And if you can look closely at the helmet, you'll see all the little holes. And these holes are not round. They're actually slots. They're lines. Because the first version of the Gamma Knife was a knife, in fact. It didn't make a spherical dose plan. It made a cut. And it was used to cut fiber tracts in the brain for Parkinson's disease or pain. It was not good at treating tumors because tumors were not linear or rectangular. And it wasn't until the second unit, 1975, that the holes were made round. And in fact, this Elekta, who's helping to sponsor this, was not even a manufacturer of the early Gamma Knife units. It had to be made by multiple companies, including the Swiss company Nucleotech, which put together the different components that Leksell wanted for a Gamma Knife. This is the Sheffield unit, 1983. It looks sort of crazy, in fact. And then the LINAC world, which eventually became the CyberKnife world, took off with Bill Friedman and others, the University of Florida, at Harvard, and several people in Italy. and Argentina developing LINAC systems as well. And then eventually John Adler, who had visited Leksell, wanted the concept of a gamma knife in a LINAC, and not just for the brain, but potentially for the body. And this took a lot of effort. And just by complete chance, about 2 minutes before I started this talk, Dr. Adler sent me a text. He wants to talk after I finish, not about this, but maybe he has some question for me. So this became this first unit, and indeed, in the United States, CyberKnife took off more for prostate cancer than really it took off for brain cancer. But Stanford really was the preeminent place for that. Now the Gamma knife has evolved over time, as I showed you the early prototypes, and mostly related to automation. And by the time we got to the C unit and the 4C, the bed itself became robotic, and then the current uh, machine still had the same radiobiology but improved patient efficiency. And this is after the flood in New York, where I had to redesign an entire suite. And this is the current model of the Gamma knife, the Esprit unit. And this arm on the left is a cone beam CT, which allows a different type of stereotactic registration to be done on the machine as opposed to based upon a frame. And so the workflow is either frame placement, and this is the new Vantage frame or the old G frame, or one can use a mask, depending. And I use both every day. I use both of these depending on the disease states. Certainly, if I'm doing a vestibular schwannoma or a skull base meningioma, they are getting a frame every time. And certain simple types of cases like a metastasis, limited number of tumors, or maybe a convexity meningioma or something quite simple, I will use a mask. But anything that requires precision, high precision radiosurgery, I put a frame on. Frame takes me 2 minutes. A mask takes 9 minutes, and then we move on. So there's so many of these devices now available in 2025, and of course, the John Adler's next project was the modified linear accelerator into the ZAP system and other LINACs, as you see here. Just a word about ZAP versus CyberKnife, since they were both developed from same mindset. And I'll show you a map of current ZAP installations. This is a self-shielding robotic LINAC. And again, as a brain device, Adler's original vision was to create a less expensive radiosurgery tool that perhaps different hospitals across the world could have could have access to. But you can see sort of this list of the kinds of cases that are being done with it in early experience. Typical tumors, little, obviously not too common on AVMs and really none on trigeminal neuralgia. And there's been a lot of interest over the years at comparing platforms. And when people ask me, what's better, this or that, and I say, well, these are just tools, so the tool doesn't do anything other than reliably bring the radiation where you want it to it. And there's obviously some differences there, but this is really based upon the physicians. It's the doctors deciding who to treat, how to shape the radiation, how much radiation to use, what the fall off should look like, where it should go, all of these types of things. And you can see here the Varian true beam single or edge or a multiple isocenter plan. And you can see that the dose fall offs are quite tight around the target. But once you get to the surrounding brain, they become very different. And people don't talk about this too much. They say, well, it's a steep fall off, but what's the regional brain dose getting? The regional brain dose is much higher with some of these other LINAC systems. That's completely clear. And the Gamma knife Esprit really has the lowest total brain dose. Here's a ZapX plan here, but these are both in, I would say, in the good range. So if you look at some of these LINAC systems, this is the volume of normal brain receiving identical dose plans, and the tightest fall off and lowest amount of regional brain dose is with these types of devices. You can see that there's a price to pay, and some of the price to pay can sometimes be treatment time. I don't know if this is accurate at 2.5 hours. I don't treat much at 2.5 hours. I did a meningioma this morning that took 30 minutes, and I did another tumor that took 15 minutes. But some of the LINAC systems can be very quick. There's no doubt about that. So if you look at the landscape of these different devices, the thing about the Gamma knife is that there's a sophisticated large user base and a huge amount of published outcomes. The CyberKnife system has been sort of an issue, and it's one of the reasons John Adler left left Accuray, was sort of a lack of support for research, and Elekta had always supported Gamma Knife research in a very strong way, and John didn't like that element there. Tomotherapy sort of didn't catch on. Novalis and Brainlab's Novalis system has a really strong, dedicated user base with a lot of commitment to software development. I don't think Trilogy has been a breakthrough for Varian. There's a Chinese rotating system that really didn't make much impact. And the Zap software, when I've looked at it, I've had concerns about it. There's some new software that people say is better, but I haven't seen that yet. And Proton's extremely expensive. Do they have a role? We use it for some pediatric large tumors, and we use it for some craniospinal radiation. It hasn't pushed into the radiosurgery space really much at all. But I think if you're looking at, should you buy a system? What should you buy? You should be asking questions like, what diseases do you treat? How many do you want to treat? How many per year? How many per day? What's the workflow? All of this. In the United States, radiosurgery is part of neurosurgical training and it's part of radiation oncology training. And I've been a director of the American board. I used to run the oral exams for the United States. And it's on the exams, it's in the mainstream. And of course, as you all know, people want it. Referring doctors want it, patients want it, families want it. And so I like to show this slide because in the height of COVID in 2020, you can see my practice at NYU was the most COVID-proof neurosurgery practice, where everybody else's practice sort of died because people didn't want to go to the hospital. They didn't mind coming into a sort of a self-contained suite and get in and out quickly, and so we were able to continue to treat, a high volume of tumors. But there's always threats. Anything we do in medicine has threats. And what are the threats to a busy program? Drug treatment for brain metastasis. Is that going to reduce the number of radiation procedures? So far, it really hasn't made a huge difference. There's other subspecialties. ENT has had to sort of learn about vestibular schwannoma radiosurgery, but now they have. And of course, there's always, I mentioned the other types of biologic things that are coming along, and one has to understand that. So let's get into the techniques. Here's frame application, for which in local anesthetic is probably the greatest invention of all time in medicine. And you put some local in and you can put anything on somebody's head. And of course, we do it in the operating room all the time. So here's frames and masks, and we use these all the time. As I mentioned, it just takes a couple of minutes. It feels tight, then it feels fine. There's no movement issues. There's no monitoring concerns, and treatment is reliable. And who likes the frame the most? My radiation oncologists love the frame the most because once it's on, we have no monitoring issues related to a mask. My masks are made by my physicist and my radiation oncologist. It takes a little long. Comfort is variable depending on claustrophobia. There's some movement concerns, and we'll show some of that. So it sort of goes to the next question is, do you do it in a single session? Do you do this in multiple sessions, or external beam, conventional fractionated radiation? Back in many years ago, people talked about single session radiosurgery, and there was a lot of dogma that was based upon, to be honest, very little, that says, radiosurgery should not work for slow dividing tissue like meningiomas, AVMs. It just doesn't work. And that was wrong. And it was wrong because the radiobiological strength of radiosurgery is so much higher than a traditional fractionated. And there was no way to really understand this. So this is why tumors shrink. Even the radio-resistant melanomas and renal cells tend to respond well. So here's mass-based treatment, and you can see we're monitoring the patient's nose position with fiducials, and this is under 0.5 millimeter of movement. And you can see here's another one, a pituitary tumor doing quite well there. But here's somebody moving around. And every time you see yellow, it means the machine has stopped. They have gone beyond tolerance. And so we have to do another cone beam CT, set up another registration. And if someone is nervous or anxious, They may have 4 or 5 of these during a treatment, and suddenly a 20-minute treatment takes an hour, and it's hard to lie in a mask for an hour. The frame, it's open, no problem. Let's get into the different disease states. So brain metastasis, as I mentioned, are the #1 indication for what radiosurgery does. And about 11 years ago, I wrote this paper with a number of key radiation folks and oncologists talking about what needed to change. And what needed to change was really an understanding of the tremendous amount of data that's coming out. So about 2 years ago, I took all my brain metastasis patients at NYU and their images and all the clinical information, and I put it out there on the internet for anybody to play with. So it's free, it's in the public. It's de-identified, and we call this NYU Mets. And it's hosted by Amazon Web Services based on an NVIDIA AI platform. And people now use this. About 7 different institutions do research on this huge database. This is the world's largest open access brain tumor segmented, drawn and contoured database. And we've been able to do all sorts of things, like, for example, why do patients die from tumors? And you can see across the spectrum of different types of cancers, mostly lung, melanoma second, and breast third, but we treat a lot of these things. And what's been so amazing is that until about 15 years ago, median survival of any clinical trial for brain metastasis had a median survival of about 10 or 11 months. And now we've blown past it all. Even 4-year survivals now in lung cancer are approaching 1 out of 3. And people are being cured of these things, mostly due to having a very strong response to immunotherapy or certain targeted therapies and getting the brain tumors under control. So you can see that melanoma, even median survival, used to be 5 months, is now at 2 years. And this is absolutely sort of incredible. Now, of course, back in the old days, and I don't know, probably not in Saudi Arabia, but maybe in some other countries, whole brain radiation was, the standard practice. And every one of these dots is telling you that this is our decision boundary for the use of whole brain. So by 2019, these are radiosurgery cases. Anything under 25, we're doing radiosurgery. So above that is whole brain. And you can see the number just keeps going up. Back in 2012, when you had 10 Mets, we would give you a whole brain. Under 10, we would do radiosurgery. Now we're using radiosurgery and targeted therapy for what I call whole brain cancer care. Now, if the oncologists are saying, well, I just put them on a drug and we'll see what happens, we don't need to do radiosurgery, the emerging data suggests that if you defer radiosurgery, the results are not as good. So the best thing to do is both, is targeted therapy and radiosurgery together. Small cell lung cancer was one of the other key drivers of whole brain radiation until this multi-center paper came out 5 years ago now, which showed that radiosurgery is equal to whole brain without giving somebody whole brain radiation. So that's changed small cell lung cancer. And I mentioned potential cure even in melanoma in patients who have a strong response to immunotherapy. This is now happening. And it used to be that 4% of patients were long-term survivals in melanoma. This number just keeps going up. So what's the upper limit? When do you have to consider whole brain radiation therapy? And that upper limit keeps changing. But in our practice, if they have clear leptomeningeal disease or miliary disease, they need whole brain radiation. But if they have focal leptomeningeal disease, like this tumor in the auditory canal in lung cancer, or just focal sulcal enhancement, we will do radiosurgery for this. And as you can see, here's the response in the auditory canal. And that can be impressive. Half of these patients later got whole brain and half of them didn't. So you can use this technique here. And for example, here's an ALK positive lung cancer, which is drug responsive, but at this time it's failing. Auditory canal tumor, trigeminal nerve tumor. This is lepto. And here's the response more than a year later. So radiosurgery plus drug. And these are people who have failed drug. There's colorectal cancer, and you can look at this tumor on one side of the cerebellum, and there's a sizable tumor on the other side of the cerebellum. And when I was a resident, this was always a surgical resection case. The problem is the patient's actually feeling fine, and she's a physician. So in this situation, I just put them on steroids and do radiosurgery and then watch them closely. I give them a 4-week taper, scan them again, and if it fails, then we resect. But if it doesn't fail, like here, you can see the response at 4 weeks, then we didn't need to resect her. And so this is how we mentioned if they're neurologically well. Obviously, if they're neurologically symptomatic, they need a resection for a big mass. So the failure rate of upfront for larger brain tumors is actually low up to a point in patients with minimal symptoms. That's the point. So you can achieve a lot of interesting biologic responses with these different approaches. And again, I go back to some of the studies on the fall off dose for larger tumors. This is looking at gamma knife perfection to cyberknife to Novalis. And again, the tightest fall offs have been with the gamma knife. And why is that's not hard to explain? It's because the machine has 192 beams. So each of the beams on the way in is very, very weak versus if you have a Linac with multiple, only be 5 arcs or 7 arcs, or a limited number of angles or nodes with a CyberKnife device, you're going to spread out the radiation a little more than with the gamma knife. So again, this is one of the physics differences. I bring it up the question, does it matter? That still remains to be seen. So here are the dose interplays. Again, the tightest fall off gamma knife here had a low dose range, for example, at 4 gray. You can see at 12 gray, still better, but the other devices sort of look similar. Does this matter for cognition? Remote brain dose? Potentially. So, but as I mentioned, price to pay. Longer treatment times, faster treatment times with a variant Linac, for example, but with more brain dose. So survival, we're so excited about long-term survival in all of these cancer types, and the publications just keep coming out. And what I've been doing now, and the radiation oncologists will be interested in this, I've been going to lower doses. I actually don't think that a lot of these doses that came out of RTOG in the 90s were necessary. I never give more than 20 gray, and a lot of people give 24 gray. I've been pushing the low dose range, 12, 13, 14, which works great in breast or lung, but not in melanoma. So if someone has multiple tumors, let's say they have 20 tumors, you can give them all 12 gray, and believe me, it'll work great. So I think we can be happy at the lower dose range. Let's move on to other types of tumors. The next I want to talk to you about is the commonest benign tumor, vestibular schwannomas and meningiomas. And there's never been a randomized trial between resection and radiosurgery, but there are now 8 matched cohort comparisons between resection and radiosurgery, and they all show the same thing. Radiosurgery beats resection on facial nerve and hearing. Balance and tinnitus is equal. Tumor control rates are equal. And so that's really the issue. So here's a small intracanalicular tumor with good hearing. We treat it. Here's the 2-year scan. You can see it's losing contrast. Here's the 4-year scan. I call this the hope. This is what everybody hopes. It's going to shrink. It's going to shrivel up. We'll hardly see it. This is not the norm. This is what can happen, but this is not the norm. The norm is that it shrinks a little bit and stops growing. Here's a 77-year-old woman. Here's the 19-year follow-up scan, a case from Pittsburgh. And here's a 29-year follow-up scan. It's still getting smaller. And we were amazed at these. When I first wrote up the first 5 to 10 years experience in the New England Journal of Medicine, this was 1998, we had no idea what biologically was going to happen. And it's scar tissue. So the body is still remodeling scar. And it's just amazing to see these long-term outcomes. And recently, the 35-year meningioma paper came out in neurosurgery, and this month, the 25-year Mayo Clinic meningioma gamma knife paper came out in neurosurgery. So we have very reliable longer-term data. One of the sort of the hot topics right now is just how fast do they grow? And so if you're going to make a beautiful dose plan, you probably want to know how fast they were going to grow if the purpose is to stop the growth. And if you're trying to stop the growth, is the purpose to preserve hearing, preserve other neurologic functions. And one of the things we have found is that here's the tumor, here's the cochlea. And I first published on cochlear dose back in 2009, and most people follow that rule of keeping the median dose, the mean dose under 4.2 gray. But this is space. And if this tumor fills the whole auditory canal so that it's closer to the cochlea, like in this case, this is not so easy for hearing preservation. But if there's more than 4 millimeters, hearing preservation actually happens at a pretty good level. So the point is, and I tell my patients now, if there's room here, don't wait. Because what are you waiting for? You're waiting for it to grow here and then you want me to save your hearing? It's probably not going to happen. So again, it comes down to the anatomy. And this is the same thing for surgical removal. You want room in the lateral auditory canal for hearing preservation. So, the patients years ago used to say, well, it's benign tumor. What if I radiate it? What's the chance of delayed malignancy? The ENT people particularly saying, oh, it's scary. You're going to get delayed cancer. I've never seen it. We did this study of 5,000 cases with benign disease, more than 5-year follow-up. And we found that there was 2 cases. We found that the long-term risk was similar to the general population risk. So this is what I tell my patients on that risk. It can't be 0, but it's extremely minimal. Let's talk about meningiomas. This was the first meningioma paper. It was 1991. It was on 50 patients. And then the 5 to 10 year data came out, and then 1,000 meningiomas came out, and now the 25-year and now the 35-year data, as I mentioned, has come out. So this is from Stockholm and Pittsburgh, and then other centers in Europe as well. So one of the great things for, just the great questions about a meningioma is you look at the scan and you say, well, how do I know that's a meningioma? It's a white thing on the dural base. And, this is actually a hemangioparasitoma. We know that because it was partial surgery. This was a trigeminal schwannoma. So we asked ourselves in one study, how often were we wrong at calling something a meningioma without biopsy? And the answer was 2.5%. And it was mostly a higher grade meningioma. So here's a petrocavernous skull-based meningioma. Most of these present with diplopia. And this is a gamma knife plan with about 18 isocenters to make this sort of very irregular shape, a little bit down the tentorium, into the sella as this grows. And the dose for these is usually in the 12 to 12.5 range. It doesn't need to be more than that. Here's another one. It's a little smaller. Here's 13 gray. Petrus apex presents with a 6th nerve palsy. If that diplopia has happened within a couple of months and you do radiosurgery, there's a really high chance you will cure their diplopia and improve them. But if you sit on this tumor and say, well, let's watch it and see how fast it grows, if they have diplopia for like 2 years, it's not going to get better. You have to treat these people earlier. And at 10 years, in patients without prior surgery, what I call primary radiosurgery, there's a 95% tumor control rate. That's with no prior histology. And you can see this tumor wrapped around the anterior communicating artery complex. We treated it in 1989. And here's a 21-year scan of the sort of the shriveled remnant in that area. And what we haven't seen in skull-based tumors are infarcts, perforator infarcts in the brainstem or in the basal ganglia. And you might think, well, there's all these perforators around here. Aren't they getting closed by the radiation? The answer was no. We don't see that. Here's a really old gamma knife plan of a tentorial meningioma. Here it was. And here's an 18-year follow-up now. You can see knuckling into the side of the brainstem. Now you can see the space around the brainstem. And it's really fun to see some of these old scans. And the radiation oncologist will know that if you give somebody external beam radiation, sometimes without even shrinking the tumor, they can improve. And here's a woman who comes in with a complete ptosis. Eye is closed, and 4 months later, her eye is open. And even though the tumor looks the same, but this is the 6-month effect, probably like, why would this improve? Is it some metabolic effect on the nerve? It's not clear. This is an interesting concept of meningioma-related trigeminal neuralgia. So it's the petrous apex meningioma affecting the fifth nerve, causing bad trigeminal neuralgia. And I have a bunch of these people who are very elderly. This woman's 90. I mean, are you going to do a decompression of the nerve here? No, she's 90. But this is combined radiosurgery to the tumor, where I've made the 12-gray dose fit the tumor with a change in the dose plan so that centrally the nerve's getting a high trigeminal neuralgia dose with a tumor margin dose. So essentially, I've shaped the nerve dose so that the fall off looks like the tumor. And we've published on this. This is not my idea. A Korean neurosurgeon came up with this. And this has always worked. I've done this about 6 times, and it's always been successful. I think it's a really interesting biologic thing to do for a petrous apex tumor causing that. There's some recent papers that have come out comparing, should you do radiosurgery for an asymptomatic incidental meningioma? We all see incidental meningiomas. Should you watch them? Should you treat them? And this was a matched cohort comparison between observation and radiosurgery. And the data suggests that the safety of radiosurgery is so good that you can do this in this setting. And so we're comfortable with that. We give it as an option to patients. Here's a woman with some headaches, has a growing tumor. Every neurosurgeon would remove this. I mean, nobody is not going to remove this, but she doesn't want it removed. She says, no, I'm not doing it. Can you do radiosurgery on this? Fine. We do. Here's the 2-year response to 13 gray. The patient was right. Again, it's a biologic response. If it doesn't work, we can still remove it. So there's still a plan B. So, my eyes have been opened over the years to the power of this approach. Is there a chance of brain edema? Sure, because here's a meningioma at 13 gray. Here's the blood-brain barrier changes as it's breaking down, which here's the flare, and it goes away over time. Flare goes away. This is not radiation necrosis. This is the inflammatory changes as part of the tumor response, leading to a secretory effect. You see this in acoustic neuromas. You see this in meningiomas. It heals up. Here's one with a meningioma. Again, you can see the flare change at 3 months, at 6 months. This one caused problems. This one caused seizures in the leg. It eventually regresses, and the seizures get under control. But, this was an issue. So there's no free lunch on some of this. Pituitary tumors. This goes back to the early days at Harvard using the proton facility. And I was at Harvard in 1984 as a student. This is me in 1984. And this is how I got exposed to this field, because Ray Gelberg, who's here in the bottom, Dr. Gelberg had the world's worst list of AVMs being sent to him. They had a 1-year waiting list of these things. And I worked with him, and I saw that I was so interested in arteriovenous malformations that I thought this was the future. And at the same time, of course, work had been going on with the Gamma Knife program in Sweden, and some of the earliest cases were in pituitaries. And if you look at it, it's 1978. There's no MRI in 1978. They barely had CT. A lot of these early cases were treating the sella. So they would just treat the expanded sella or calcification in the sella. And that's where this field starts. I have a registry with all my patients and all the data. So we built this years ago, and I have a student who enters my data in every day. But this is the pituitary part of the registry where I can include all the prior information, drug therapy, everything we did to the patient, and all the follow-up scans, vision, cortisol levels, and so on. So I have full fidelity information. And this is the information that was put into the brain metastasis system I showed you earlier, including all the follow-up. So this is entered every day with every clinic visit that I have. And this has led to a very routine use of radiosurgery for pituitary tumors after resection. So if there's visual compromise, there's still residual tumors, say in the wall of the cavernous sinus, then we will do it. And as you can see, the success rate is very high. Here's such a case. tumor in the cavernous sinus. Here's 20 months later. Here's 40 months. Dose is 13 gray. Highly safe to vision. Dose is not high. If it was a secretory tumor, that's a different thing. Here's another one, 13 gray. There's a little bit of room here. This is fine. This is really no risk to vision. Now he's 89 years old. Here's the 9-year follow-up, and you can see that. If it's a secretory tumor, you have to use a higher dose. So distance between the top of the tumor and the optic system is more important. The chance for remission in acromegaly is in the 50 to 60% range. It takes time to work. For Cushing's disease, it's about the same. Again, it takes time. It takes time to work. What's the chance of hypopituitarism from radiosurgery? It's about 30% at 10 years, which is much less than traditional radiotherapy to the pituitary, where it was almost 100%. Couple of finishing thoughts on AVMs and then trigeminal neuralgia. So the AVM is such a fascinating thing for neurosurgeons to care for, and I'll show you some wonderful things regarding the biology of this. So what we typically remember is that radiosurgery takes time, and there's a cure rate maybe after 3 or 4 years. But here's an AVM, and I'm showing you a 3-month scan, not a 3-year scan, where the early inflammatory effects of this in some lucky way led to occlusion of the draining vein without bleeding or signal. And so at 3 months, the MRI almost looks normal and the AVM is closed. The future of AVM radiosurgery is going to be trying to understand this and speeding it up. Here's a 19-year-old college student who had an MRI of her neck, and they found this monster in her cerebellum. A lot of people in New York wanted to remove this, and she eventually had radiosurgery, but not at a high dose, 17 gray. Look at the 7-month scan as it starts to close off. Look at a year, just past a year. And here's the 3-year angiogram. This is probably one of the most interesting things about this. This is lower dose radiosurgery for larger volumes. What do you do for this type of person? He's a 27-year-old financial consultant. He's got an intraventricular hemorrhage. Here's his AVM in the corpus callosum. Look at the whole corpus callosum is AVM. This is what the angiogram looks like. He's got, essentially, it looks like a grapevine of AVMs hanging down. Look at this. We did this in 2 stages. So this is a multi-stage. This is stage 1. We did the posterior part of the callosum. And then we brought him back for the anterior part of the callosum now. So the blue is the old stage 1, and the stage 2 is the front. Stage 1, stage 2. Here's at 2 years. Here's at 3 years. Complete obliteration of all of that, no shunting, and a normal looking scan. You can see there's no flow void in here. Almost close, almost looks normal now. Absolutely incredible. Not high dose. You can see a little signal change right here, the scar of the closed AVM. Finally, trigeminal neuralgia, one of the oldest concepts that Lars Leksell explored. I was very intrigued by this because in Pittsburgh, under Peter Janetta, we saw a lot of trigeminal neuralgia patients. So I put together our modern approach. I did the first case in America in December 1992. And once we got to 50 cases, which took 5 centers to put together 50 cases, we published this in 1996. And within 3 years, 10,000 people in the world had been treated. This really, really took off. And we did this we didn't even know how it worked. So I did some baboon experiments where I did the trigeminal nerve of a baboon, and we studied it under electron microscopy, and we tried to figure out what the best dose was. And we did randomized trials on how to treat the nerve. We treated the whole nerve, a little part of the nerve, and then eventually the long-term data started coming out from here and from Marseille and from many centers across the world. And more recently, people are looking at, and especially for the radiation oncologists, the concept of BED, which relates to dose and time effects on tissue and whether that is relevant. So this was a study that was just published. And it may be that there is some BED effects on getting pain relief faster and maintaining it without sensory dysfunction. And I would turn your attention to that article. So just to finish, a a radiosurgery program can really touch so many elements of brain radiation oncology and neurosurgery. And if your interest is in to care for all of these elements, you really need a dedicated device. You needed neurosurgeons and radiation oncologists who are also dedicated to it, as well as physics staff. You need a supportive administration who get it, including people in information technology, because there's a lot of software elements here. And neuroradiology really has to be a great partner. And we look forward to further contributions from the Saudi community to what is one of the most interesting ways to tackle complex brain problems. So thank you so much for your attention today, Shukra.
Professor Doug Konzioka, thank you for the amazing talk. Someone texted me, why did you introduce Dr. Konzioka in a very short 2 lines? My answer was that the name is the brand. Your name is your brand. You have more than 40 years of experience. We all know you. No one in Saudi, we all know you. We all study your paper. You should show in half an hour an excellent leadership skills. The academic achievement is a role model for every one of us. The clinical excellence, the research and innovation, and the team playing. You didn't show that you have a lot of papers, prospective and randomized studies comparing and combined radiosurgery and radiation to other treatment approaches. So it's not only someone would think you're advocating more for radiation, more than surgery and medical treatment, but that's not correct because half of your publication is combined treatment. Thank you for this. Thank you for accepting the talk. I have in the audience more than 52 neurosurgeons and radiation oncologists in Saudi. They are distributed all over the kingdom. So your talk reached the full kingdom just now. I have 7 questions, but I'm sure each one of them have questions. So I'll start with one, and then if there's no other questions, I'll continue with the rest. The cases of 20 METs. When you say 20 metastatic lesions, of course you divide them in sessions, right? So which lesion do you treat, and how many lesions per session you can do? And gamma knife, I guess it's only one, but can you tell us more?
Yeah, if someone has, you might not like the answer, but if someone has 20 tumors, we treat them all right at one time. And each tumor takes about 5 to 8 minutes to treat. So if it takes 20, it might take an hour and a half or 2 hours. And the patient will just lie there comfortably, put on some music in the machine, and they will lie there for 2 hours and all 20 will be treated. And then it's done. And then I will see them in 2 months and we will see how they do and make sure they don't have any new ones. The most I've ever done at one time has been about 35 tumors in a younger woman who could tolerate that. That's about 3 hours of lying there. And so that's how we do that. So if it's a larger tumor, sometimes we'll do it over 3 sessions and we'll break it up or do an adaptive approach where we would give a low dose and then rescan in a month and see. But multiple tumors, we treat them all the time and we just do them all. So it goes robot. Remember, the bed is a robot. It just goes 1 to the 1 to 1 to 1 to 1 to 1 to 1 like this.
Thank you. I think we have Dr. Walid Murad. He has a question. Dr. Walid, can you?
Yes, thank you very much for the great talk. My question is, what was the acceptable mean brain dose when you treated more than 20 METs or 30 plus METs? Thank you.
Yeah, this is an excellent question. We published a paper last year in one of the physics journals that was where we simulated multiple tumors in different locations. And we wanted to know how many tumors essentially gets to whole brain radiation therapy. Like if you treated 100 tumors, all the dose in the middle must equal similar to whole brain RT. And it turned out the number was actually about 45 to 50. So the dose fall off is so steep. And I also showed you the use of low doses. So a couple of things. Let's say somebody has 20 tumors. First of all, these are not 20 big tumors because 20 big tumors, someone is not going to live and they usually are so sick. So it's usually 20 small tumors. And let's say they are 6 millimeters, 8 millimeters. The volume of that is very small. If you add up the cancer burden of 20 tumors that are 6 millimeters, the whole volume, total volume, is probably 1.5 cc's. This is actually smaller than one big tumor that's 3 centimeters or 2 centimeters, which has a 6 cc, 5 cc volume. So there's much less cancer burden with small multiple tumors. So most of these patients have minimal symptoms, and the dose fall off is so steep around each tumor that the remote dose is very, very low. Even within, a centimeter, you're down below 1 gray, maybe 2 gray. So that's really not a concern. And because of that, we don't see the white matter changes that you see after whole brain radiation therapy. We don't see the leukoencephalopathy a year later or 2 years later in people who get lower dose multiple isocenter radiosurgery, which is the good news. And because their stem cell populations are around the ventricles are being maintained, which is part of brain health.
Dr. Yahya just asked, when do you do whole brain? I think you just answered that.
Yeah, I think that, as I mentioned, it's for leptomeningeal disease, diffuse leptomeningeal disease, and or miliary disease. Sometimes you see 100 small tumors, but it's interesting. That's what I would say they should get whole brain radiation. But I have medical oncologists, like lung oncologists, and let's say we have a patient who's got EGFR positive lung cancer. What they want me to do now is treat the 10, 15 bigger tumors and leave the rest for the drugs. Because there's a good chance that the targeted therapy will have an impact on all the little ones that I don't treat, and we'll watch them. And if it fails later on, then we'll do more radiosurgery or whole brain radiation. The medical oncologists are really pushing to get away from whole brain radiation because the patients look better if they don't get it. And so the medical oncologists can continue their systemic cancer care.
Quick question, sir. So do you keep your hippocampal structure under a certain dose when you treat many lesions in the brain using the gamma knife? Do you contour it and put a constraint on it? Thanks.
Yeah, we actually published a paper on what the hippocampal dose is amongst all the patients with more than 25 tumors. It's very, very low. We also asked the opposite question, which is if you do hippocampal sparing whole brain radiation therapy, what's the chance of they get a hippocampal met? Okay. It's like what percent of metastases end up in the hippocampus? And the answer is like 5 or 6%. One of my radiation oncologists, he likes to say, the best way to spare the hippocampus is to do radiosurgery, because cognition is not just the hippocampus, of course, it's the whole deep limbic system and the frontal lobe projections and the parietal lobe projections that surrounds, and these projections surround the ventricles. So this is not all about the hippocampus when someone starts to think about the best chance for cognitive preservation. So hippocampal dose is low, but if someone is young and needs whole brain radiation, we will do hippocampal sparing radiation therapy for sure. We do that.
Okay, last question for me, and I promise it's going to be the last one. Now we are using the MRI Linux based, and this provides us an excellent view of sometimes of the brain motion within the skull.
Yeah.
Does this information make you change any kind of practice or adding more margin or maybe something like that? Can you teach us on that, please? Thanks.
Yeah, I mean, well, when the brain moves with pulsation. Any neurosurgeon who's doing, open surgery sees the brain move. We like that. It's healthy. The brain is pulsing. We like it. But it always goes back to the same position. And so we assume that for the purpose of targeting, it doesn't move to a different position. So it's random, it's sort of like pulsed gating. So we don't put a margin on for that. This is not a movement issue in a closed skull environment. And remember, the other question, if you want to take that argument further, the patient is being treated in the same position they were imaged in, which was supine. You might say, well, they have a lot of atrophy. If I flip them prone and the brain is sagging, is that stereotactically moved from the supine position? You could make an argument for that, but the imaging is the same as the treatment position. So and people don't have a concern about that, really.
We have many questions. One of the questions I had was made by the audience. What is the gap in treatment for AVM in multiple sessions?
When we first started to do this, we made it up. So because there was no guidance here. And so we came up with 4 to 6 months. I can tell you that in Pittsburgh, they sometimes like to push 3. I like to do 5 to 6 months. And I get an MRI scan before I do the second phase to see that there's no T2 change or something that might make me wait more. So I usually wait 5 or 6 months.
Do you plan the segment your treatment according to the angiogram, the dynamic angiogram?
Yeah. And so they at both stages they'll get an angiogram. So we'll get an MRI, an angiogram, and a Dyna CT angiogram. So it's very fast for us to do another angiogram, particularly through the wrist nowadays. Many, the radiologists and are doing it like that. So I like to have the best imaging every time.
And how do you plan which segment you start with, which part of the AVM?
I tend to, nobody knows for sure what the best answer is, but if you were to do it, you would say you don't want to do the venous side first. You want to do the arterial input, get that reduced before you tackle the venous side. So I tend to err on usually the more inferior or the more arterial input side first.
Okay, we have a nice question here. When do you consider 2 lesions, 1 lesion?
When do you consider 2 lesions?
What's the minimum distance between 2 lesions that you're saying that this is 1 lesion I'm going to treat?
Yeah. It's a great question, actually. That was something we discussed this morning in a case, as a matter of fact. I think if there's a clear separation of 2 or 3 millimeters, they're probably separate, but you know that there's probably some microscopic cells in the middle. And of course, the radiation dose will fall off there. It's not like it's getting no dose. So whenever you're treating 2 tumors very close together, remember when you do the follow-up scan, there's a good chance it's going to look maybe worse because of the blood-brain barrier change from the brain in the middle, making it look bigger. And sometimes that makes people nervous, including the radiologists or oncologists. They think it's bigger, but no, you biologically manipulated a region. And so you have to understand that's what it's going to look like.
Dr. Ashraf, you have a question you want to ask your question? His question is about re-irradiation for brain mets in your practice. What's the tolerance?
Sorry, what's the question again?
He's saying in re-irradiation of brain mets.
Re-irradiation.
Yeah.
Yes.
What's the tolerance parameter?
Yeah.
You follow. Yeah.
Well, let's say somebody got 18 grade to a brain metastasis and it regressed a little bit and then it grew again. When we first started to do this, you might make the argument that, well, the dose didn't work, so you should use more dose. And then other people would look at it and say, well, it already got some radiation, we have to use less for safety. So it depends on the brain location for me. If this isn't a location that I can go resect with very low risk, I will push the dose. If it's say it's in the brain stem where we don't have that option, then I will use probably a little bit less or the same, depending on the volume. And sometimes it might not even be the whole thing that needs to be treated. Sometimes it's just the edge. It might be a margin failure, like the main part of the tumor looks fine, but part of the top got maybe a little too little and is growing there. We just treat the top. So that's not a great answer because it could be more, it could be less. It's usually the same or a little bit less.
Dr. Abdulaziz Al-Hamad he wants to do a few comments. Dr. Abdulaziz.
Assalamu alaikum. Dr. Douglas, thank you very much for this nice, interesting talk. We are here at Prince Optometry Hospital. We are the only center we had gamma knife in Saudi Arabia. So if you allow me, just go through with you through few points. Number one, we try to do like retrospective studies for some of our cases, and we found that like it's for a single brain lesion. I disagree with you, but I think we are going more with memorial paper 10 years ago. Controlling the outside, the extracranial disease is the most prognostic feature for the whole brain metastasis and for the survival of the patient. Still number one. We did a review for almost 19 patients who had single brain lesion. We found that the extracranial disease progression is the most prognostic feature. For the AVM, I think we found that the worst prognostic feature, I don't know if you disagree with me or not, is the youngest patient. As the patient is younger than 25, they tend to have recur or persistent disease compared to the other groups, even compared to the size of the disease. One of the most challenges we have, I think, I don't know, when regarding the vestibular schwannoma, is the wrong interpretation by radiologists. We have a lot of patients. We treated almost 40 patients with vestibular schwannoma, 5 or 6 of them. They have stable disease. However, they develop cystic component within the lesion. We didn't know it is related to the necrosis or not. But the radiologists keep saying it is progressing the disease, the size is going bigger. And we keep telling the patient we cannot do anything about the cystic component of the vestibular schwannoma. So, the last thing is about the trigeminal neuralgia. I believe a lot of our patients, we cannot do like clear pain assessment, since that majority of the patient, they are afraid of to be weaning of painkillers. So we try to go through the history and what they're feeling, but we found that the pain assessment around 12 to 18 months post radiosurgery is the most prognostic feature that the patient will never need another further treatment. Thank you very much again.
Yeah, thanks for your comments. I completely agree that the extracranial status of the brain metastasis patients is the most important feature. And I showed a paper of why people die. I didn't show you the data, but death from a neurologic cause is only 9% of the time. So we have mostly solved the problem for most patients they're not dying of their brain tumor. So the systemic therapy, just as you said, and the extracranial status is the most important. When it comes to the AVMs, we find that the young patients do just fine, but remember that, the AVM, if you're treating an AVM in an 8-year-old, the AVM is likely still in development, probably until adolescence. So, you can have an interesting response, but the brain may still be making malformation there, and you have to really watch them going forward. For the cysts of the vestibular schwannoma, we see them from time to time. If it becomes a growing mass that's pressing on the peduncle or causing some issues, and sometimes we have to operate on it and drain the cyst and remove that part of the tumor, because that's biologically causing issue. I've even done stereotatic aspiration of a cyst in a really old person, like late 80s, just to drain it. And, so sometimes that needs to be done. And the trigeminal neuralgia, you're exactly right. Some of these people have been taking medicine so long, they are afraid to stop. And they take carbamazepine and other drugs like it's a vitamin. And one of the drawbacks of radiosurgery is that it can wear off, as you know. And by 5 years, 50% of the patients have had some need for another procedure, sometimes another radiosurgery. It is not the perfect solution for sure, but it can help someone who's really suffering reduce their suffering.
We have a question from Dr.
But
Reed.
sorry, sorry to interrupt that. Do you have any kind of assessment for the pain control, because we tried our best as a physician, but the patient, we cannot get the real information. You see the patient not in pain, but he tell you in the clinic in severe pain, but the patient tell you he's in severe pain.
Yeah, I mean, I see all these patients in my office, and to me, it's either they are pain-free and we try to taper their medicine, or they're better but not pain-free, but they're suffering less, and so they have less attacks, and maybe they can taper a little bit, or they have no pain but they still need their medicine, so we continue like that. And of course, these are the different elements of the scale. Many often use the Barrow Neurological Institute scale of that. It's as good as one has right now, and of course, it's subjective. And as you know, so there are certain patients who have one attack of pain and my life is over, and then other people who are getting plenty of attacks and they seem to, I'm okay. So it's so subjective. There's a wide spectrum of this problem.
Okay, thank you, Dr. Abdulaziz. Dr. Abdulaziz Al-Ghamdi has a question. Do you have in NYU a combined clinic between radiation oncologists and neurosurgeons?
Yeah, we actually have a combined clinic that's neurosurgery, radiation oncology, and neuro-oncology, but it's mostly for gliomas or malignant meningiomas, this kind of thing. But for vestibular schwannomas, standard meningiomas, and metastasis, we do not, because we have so many patients. I can't have joint clinics all the time. I see patients, I do cases every day of the week, and I run clinics 4 days a week. And so I see them all, and then we do a lot of virtual discussion. And because I work with radiation oncologists every day in the Gamma Knife suite, we're always looking at cases together. So I'm always working with a radiation oncologist on a continuous basis. So we spend a lot of time looking at discussing these things, but we don't have the time to put it through a broad group. And we have our tumor board on Friday mornings where we're mostly talking about very complex cases, pineal tumors, glioblastoma care, astrocytomas, that kind of thing. I'm sure everybody in your own in your kingdom as well at each institution does this a little differently depending on the people.
We have a question. What's your cutoff volume for a single METS? Total volume.
Yeah, it goes down to let's talk about one tumor. If someone had let's say they had a large tumor, they had a 15 cc metastasis related to breast cancer in a critical location and with some swelling and not good for resection, I would put that patient on corticosteroids and likely do a multi-session approach. Could be 3 days or 5-day mask-based radiosurgery. If it was 10 cc's, I would just do single session radiosurgery for that. Obviously, if it's in a resectable location and they were medically suitable, we would resect it. And then we would do tumor bed radiosurgery, depending on the size of the bed, typically 2 to 3 weeks later. And again, they still need radiation locally, so we would do it like that as opposed to whole brain radiation. We're always trying to keep the whole brain radiation in our pocket for when we need it for leptomeningeal disease. Because if we spend it early, when we really don't need it, then when we need it, what are we going to do? So we keep it for what it's good for.
Dr. Mudathir is asking you about the redo radiation for trigeminal neuralgia. What's your thoughts?
Yeah, I only do it in patients who responded well the first time. So if it didn't work and it's 3 months later, 4 months later, they're still in a lot of pain, I don't do another procedure. I would do a percutaneous rhizotomy, or if they should have had a microvascular decompression, we would do that. I do it in patients who had worked, and then the pain came back, because then the patient says it was great. Can you do it again? It's obvious. So I do it on them, and we treat the nerve further away from the pons, and usually the dose is 65 gray, second time 80 gray the first time, with some overlap. And so that's how we do it.
I have a question. Chordomas. What's your approach for chordomas, and did it change with the subgroup in 2021, classical versus fully differentiated versus undifferentiated when it comes to radiation dose?
Yeah, the management of chordoma here in the United States has been so heavily ingrained towards maximal resection and proton beam radiotherapy. So even in New York, where we see a lot of this, of course, chordoma is not that common. Many patients will get proton beam approaches either in Boston, or we have a unit in New Jersey that I don't work with, but other people do. But the data suggests that if there's a small volume actual recurrence or nodule, radiosurgery works great for that. And that's what I like. So I don't treat a lot of chordoma because of the regular practice patterns. But when I treat chordoma, it's usually people who have failed protons and not good for more resection. And nodules are new tumor nodules are forming, and I will treat them. And it can usually work, but in that situation, the patients are usually progressing and then get into other trouble. So not often not curative, but sort of effectively palliative.
Okay, I think we'll go 5 more minutes if you allow us. I know you're exhausted
Sure.
from the questions. I have a question for you. Do you still define, do you agree that radiosurgery is 1 session or can it be 5 sessions?
Well, you trained at Stanford, right?
It's 5 sessions.
Stanford was a John Adler approach. And do you know why? Because he wanted funding for it in the United States. So he made an argument that because he wanted to do it over 3 or 4 or 5 sessions, and he wanted to call it under the billing codes the same. And so I'm fine with it. It's sort of semantics, and that's okay.
Okay, 2 more questions. The last one here. Love to hear your opinion about neoadjuvant radiosurgery followed by resection.
Yeah.
Mm.
This was started a number of years ago, and the goal was to try to reduce the chance of leptomeningeal disease after resection, so that if any of the cells spilled out when you were resecting them, they had already been radiated. I don't do it here. And the reason is that if someone has a larger tumor and it's not urgent, I like to just do radiosurgery and don't operate on them. Like, why, if they didn't need urgent surgery, then why are you doing it 2 or 3 days later anyway? Like, why not wait 4 weeks and see if it responds? Because you might not need to do the resection. So that's what I like to do. And if it doesn't work, then I do the resection. So I do a sort of a slow neoadjuvant, which is treat the tumor, assess, and then resect if I need it, as opposed to automatically resecting in 3 days. And some of the folks who started this concept have now gone to that approach, which is, yeah, let's wait a little bit and we'll see how the response is. So, but I like some of the data that's come out with it, showing indeed a lower chance of dissemination. So there may be some value to it.
Okay, I don't see more. There are more hands up, but it's already half an hour of discussion, and it's, I think, early morning in US now. It was an amazing 1.5 hours, amazing talk. We have a lot of questions. When was the last time you visited Saudi Arabia?
The last time I visited Saudi Arabia, I'm going to give you a very bad answer, which is never. So
Okay.
this is the problem. And a number of years ago, it was all planned, and then some issues happened. But I've been to Dubai, and I've been to, one of my patients was the mayor of Amman, Jordan. So I've been in the region, but I've not been to the kingdom. So that's my problem.
That's a great answer. Why? Our neurosurgery conference is coming in April 3rd to 5th in Jeddah. If we invited you, can you promise me to look in your schedule and give us an answer?
I promise to look into the schedule. Next year is already filling up a lot.
I know.
In my journal editor role, there's a lot of crazy travel, but it might be possible in 2 years. So I'd be happy to look at. We'll see. Okay, let's see that.
We'll see. Okay, thanks a lot. It was an honor. That was an amazing talk. We learned a lot. We hope we have more time with you. We can arrange for more talks in the future. Thanks, Dr. Adez Al-Ghamdi, for facilitating this. Thank you for the Saudi Association of Radiation Oncology for helping us arranging this talk. Thank you, everyone. Dr.
Thank you
Abdulaziz.
so much. Take care, Dr. Douglas. And we appreciate the time, and you're really kind with taking all these questions. You see that there is a lot of thirst for radiosurgery, and I think a trip to Saudi Arabia is warranted to quench that thirst. Absolutely. Thank you so much. Take care. Shukran.
Thank you, Dr. Abdulaziz. شكرا.
شكرا دكتور.
مع السلامة. السلام عليكم.
Abdulaziz.